I've been in Australia now for 15 months, something like that. Prior to moving, I was working in Public Health England as head of the Extreme Events and Health Protection team in PHE. So PHE is a special executive agency of the Department of Health. So one step removed from the department, but we were still civil servants. And most of my job was about working across government with other government departments on climate change particularly. And so some elements of kind of the upstream, how do we adapt, how do we mitigate, and some elements of emergency response. So you may find it hard to believe that we do have heat waves in England. It's to do with cold weather. We're a very, very floody country, so spending a lot of time working around floods and stuff. So does this mean that we're ready to go?
Not just yet.
No? Okay. So my talk today will have quite a lot of UK flavour. I've not been here long enough to really understand how climate change works or not in Australia in terms of mitigation and adaptation, although my sense is it's probably not quite as advanced in many ways as we have been, lucky to be in the UK. So I'm offering my experiences, to see if they are useful, and also to tell you some tales about where we got it quite wrong, so that you don't repeat those mistakes. So I'm going to go into my slides now while we're waiting for them. So what I'm going to try and do is, in terms of learning objectives, mostly it's about knowledge. It's about gaining or refreshing knowledge around the impacts of climate change on population health, what we know about temperature mortality relationships. They also apply to morbidity relationships too, but most of the data is around mortality. The impact of health services on climate change. We spend a lot of time thinking about, well, what are the impacts of climate change on health services, but actually health services have a very big carbon footprint. So looking at what we can do around that. And then that broader topic about co-benefits of climate change mitigation as well, and how that is actually extremely beneficial for health, but often not recognised. It doesn't often seem to be part of the cost-benefit analysis, part of the discourse. And I think that health has a really important role in making that case and helping others to make a case for action. And then the other bit I'm going to try and do is just give you some information about some frameworks for action. So some frameworks that we've used in the UK. I'm going to refer briefly to one from CDC and also the Climate and Health Alliance, CAHA, framework as well, the strategy that they have developed. So, still don't have my slides. Do I have an ETA roughly for slides? Should I just keep talking? Should I just keep going? Yeah, okay. Okay, right, so I was going to show you a slide of the Great Acceleration. Who's heard of the Great Acceleration? Do you know what that means? No? You know? Yes, go.
So there's climate kind of changes, there's changes in our climate naturally over time anyway, but the increase in heat in the last since industrial revolution is greater than ever before. Yeah. So it's the Great Acceleration.
That is one part of it, absolutely. So the Great Acceleration is something that was coined by Will Steffen, who I believe is at the ANU. Did it working with other people, particularly Johan Rockström and his group in Stockholm, looking at actually almost everything has accelerated post-war. So since the 1950s, there's been a massive increase in GDP, there's been a massive increase in literacy, there's been a massive increase in transportation, an exponential increase in let me just see what else there is, population growth, GDP, all of these things. So there's been a lot of social acceleration in increases, but those have also been matched by exponential increases in our resource use. So there's a lovely set of graphs that I would be showing you if I had them, of 12 Earth indicators and 12 social indicators that all have the same exponential curve since 1950. So that's been coined the Great Acceleration. So clearly, this change that we've been through since the Industrial Revolution, but advancement since 1950, has had massive benefits for health. We know that life expectancy has increased, infant mortality, maternal mortality has reduced, and we've had a much improved quality of life. In fact, we've pretty much outsourced all of the energy that we used to use in transporting ourselves in hard labour to all of those animals and plants and stuff that have died over millions and millions of years and created fossil fuel. So that has made our lives in many ways very much easier, but it has created a huge problem in terms of an increase in non-communicable diseases. And there are also massive equity issues. So the next slide I was going to show you is of the donut. Has anybody heard of Kate Raworth's donut? No, okay. So Kate Raworth is she calls herself a renegade economist because she absolutely refuses to accept the traditional supply and demand curves that completely ignore any externalities at all. So she has created something that she calls the donut, which is the safe operating space of humanity. And I wish I could show you a picture. If you don't have the slide, so that's not going to help you either. So when we think about all of the planetary boundaries, you can draw yourself a circle and you can say climate change, phosphorus use, nitrogen use, surface temperature, and you can say that, that in many spaces we are operating outside of those safe limits for what is renewable resource, if you like. Within the social foundation, you can also draw a circle which shows that everybody deserves a certain level of education, of social welfare, of health, of all of those social benefits that we would like to see. So what she's done is created a sort of what she calls a donut of this safe space in between overreaching our boundaries, but also making sure that everybody reaches a certain level of social welfare as the safe operating space of humanity. And she's essentially saying that we should all be trying to live in this space. Excellent. So now you can see if what I'm explaining actually has any road. Yeah, it looks like the diagram at all. Let's see. Here we go. Oh, so that's the Great Acceleration. That's what I was trying to explain in terms of this exponential changes in use. And you can have these slides afterwards. And mostly I've been pretty good at referencing. So you can go and look at the source stuff. Can you hear me okay? Do you need the microphone? Yeah?
Angie, I think they might be being recorded.
So okay, thank you. Okay, so now social and planetary boundaries, this is what I was talking about the donut. So I don't know if that looks like anything you were imagining as I was describing this, but that green space in the middle is the safe and just space for humanity. And so we need to be between the social foundation and the ecological ceiling. This is gaining traction in various different environments because it's a very easy way to try to understand what we're trying to aim for. And a group from Leeds has started mapping how different countries are performing against the donuts. Certain cities and countries are also doing a much more detailed analysis. So Stockholm has done a really interesting analysis themselves. But as you can see here, Australia is sort of sitting right up in that undesirable from one perspective, corner around biophysical boundaries transgressed, and they reckon 6 out of 7 that are measurable have been transgressed in Australia. But 10 out of the 11 social thresholds have been achieved. And the UK, of course, is not much better, performing better on one and less well on the other. So going into a little bit more detail about one of those boundaries, climate change, which is what this talk is about. This is a graph from the IPCC report that was done late last year about how close we are to breaching the 1.5 degree threshold. And I can see lots of people nodding, so people are very familiar with this. Essentially what it's showing is that we've already increased global surface temperatures by 1 degree. If we carry on the way we are, and we have really committed to quite a lot of climate change already because of the delays, the lags in the system, we're going to breach that 1.5 mark around 2040 at the moment. What we also know is that the Paris Treaty commitments, the NDCs, nationally determined contributions, are not sufficient to meet the 1.5 degrees, and we also know that very few countries are meeting their NDCs. So it's not looking very good at the moment. Some countries are doing better than others, obviously, and one of the things that I thought was quite interesting when I was trying to look at comparisons between Australia and the UK is that the carbon footprint of the UK and Australia is quite similar. It's almost equivalent, but that the population sizes are very different. So essentially, the average Australian's carbon footprint is 3 times the carbon footprint of an average Brit. That could be questioned. I think there are probably lots of reasons. Some of that is genuine, some of that may be artifact in the way we're measuring things, but I do think it's quite notable that I often hear here, oh, well, Australia's population is so small, they're contributing so little to the problem, we don't really need to do anything about it. And I would argue that actually we do need to be doing something about it, because everybody needs to be playing a part in something that is so challenging. And if we don't lead the way, others will then have an excuse not to act either. So this is also from that report about predicted system impacts. And this is essentially showing that grey bar along the middle is where we were, I think it's by 2015, so around that 1 degree mark. The bars are the different Earth systems. Purple is showing where we are at very high risk of severe impacts. So you can see that warm water corals, which is clearly something that's very important to Australia and the world, are pretty much in that very severe impacts range already, as is our Arctic region, as is coastal flooding. And I don't know if any of you have been following what's happening with the Greenland ice sheet at the moment, but there are some extremely scary graphs online at the moment showing a massive melt going on at the moment that's completely unprecedented. And of course, it's a very global issue. It's not something that's going to affect only one country. It's not going to be something that's only going to affect one community, but there are certain communities that are going to be affected first and worst. And this is just one of many, many maps you can find around vulnerability. This was done by a risk analyst group called Maplecroft in 2012. Mapping intensity of extreme weather events with social vulnerability, and of course you can see the equatorial areas, particularly Africa and South Asia and South America being particularly vulnerable there. So the impacts of climate change on health, I think, has been discussed a lot. This is a figure from the Lancet Commission on Health and Climate Change from June 2015. It's a very simplified version, but I think it's quite helpful to communicate what the issues are. So that red bar, the direct events, so storms, drought, flood, heat wave, all have direct effects on people's health. But they also have indirect effects by affecting all of the systems that we rely on, so water quality, air quality, our land use, our soil, for actually being able to grow food, and that kind of broader ecological biodiversity change. And of course, that then also has all sorts of impacts on social dynamics, and particularly things to do with social cohesiveness. As resources get more difficult, there is going to be more competition and conflict potentially, and also having impacts on things like our health infrastructure. And that, of course, is going to have a range of health effects. Mostly, they will be non-communicable diseases, but there will be communicable disease impacts too. And as I was saying, those who are at the extremes of age, who have pre-existing disease, who do not have resources to be able to adapt, are the ones who are going to find it hardest to cope with. I obviously work in health protection, so there are a range of health protection elements as well, and we are seeing some of these impacts already. People will be very familiar with the smoke events, the fire events that have been happening in quite unseasonable periods of time, so that we've had fires in the Arctic, in England, in Australia, and in California all at the same time, which is very strange and weird. We've had issues with drinking water quality. This summer in Victoria, we had problems with harmful algal blooms, which in and of themselves weren't causing problems, but they actually messed up some of the water filtration systems. So boil water notices had to be issued. We had a big Ross River virus outbreak in 2017 following flooding. And as we know, there are issues every summer with microbiological contamination of food, hot weather encourages bacteria to proliferate, people's behaviour changes, so increased risk both in food and waterborne disease that we see every summer is going to just increase further. So I'm going to focus particularly on temperature because that's the thing that I was working on in England mostly. I was running the heatwave plan for England and the cold weather plan for England. So this will be probably quite a familiar image to you. You know, I don't think I need to tell Australian physicians what heat stroke and heat exhaustion is. Okay, but I wonder if you're aware of the fact that we have this problem in England as well. And actually, the way heat is characterised in England is not really about heat stroke or heat exhaustion. What we see is because we have rare instances of heat stroke and heat exhaustion, it's not often counted in our routine administrative data sets. We've done much more work looking at all cause and then big ICD, you know, group cause of death in temperature, at the extremes of temperature. So we have, you will be familiar with the fact that, of course, that it's older people who are more vulnerable to heat than people of working age. But what we see in England is that the biggest increase in deaths with temperature is in relation to cardiovascular disease and respiratory disease. And so these aren't recognised necessarily as heat-related deaths. People aren't on the coroner's report as, you know, I died of a heat-related death. They have heart attacks, they have heart failure, they have exacerbations of their COPD or asthma. And that is caused by heat. Because of the physiological changes, the lack of reserve that they have in their bodies to be able to adapt to those high temperatures. And of course, even though those relative risks look quite small, you know, compared to a communicable disease type thing where you might be excited about an odds ratio of 5, in the environmental world, even small increases in relative risk are significant because you're talking about issues that are widely prevalent. So in terms of your absolute increase in risk, it's much bigger. So this is some work done by Gasparini and colleagues. So Gasparini's from the London School of Hygiene and Tropical Medicine. He's done a lot of work across the globe with environmental epidemiologists working on temperature. So there's a big consortium of people doing a lot of work at the moment using very, very clever statistical methods that I struggle to understand, but they're very good at sitting down with me and explaining what it means. So this is a temperature mortality curve from London that they did. So I'll just talk you through that so that you can get to grips with it, because I'm going to show several of these curves going forward. So the line curve is the relative risk of death by temperature, and the temperature axis is the mean daily temperature. So you can see a fairly understandable U-shaped curve that at the extremes of temperature, the relative risk of death increases. That grey solid line down the middle is what they call the optimal temperature. And that's the temperature at which the lowest rate of death occurs. So that's the kind of RR of 1. So that's what you're comparing against. So that's a mean daily temperature of around 19 degrees in England. The vertical dotted lines are the 2.5 and 97.5 percentiles. So that gives you an idea of the fact that there is a certain degree of deaths happening above and below that 19 degrees average temperature. The histogram at the bottom is the number of days at those temperatures. And so you can see that most temperatures are falling around the 5 to 15 degree daily average, and that the events at the number of occasions where we have these extremes is actually very low. So what this is showing, which is I think is quite interesting, is that whilst we often focus at the extremes because the relative risk is much higher, there is still actually mortality that is happening even at moderate temperatures. And those moderate temperatures are far more common than the extremes. So if you're looking at absolute numbers, the numbers of deaths that are happening at moderate temperatures are far higher than the numbers of deaths happening at extreme temperatures. So that is quite challenging for
public health professionals and emergency planners and stuff, where we often only think only at the extremes we need to put out alerts and things and warnings because it's extremes, because the risk is higher. We are seeing temperature-related mortality happening at moderate temperatures. So you can think that that is what that curve looks like for the UK, for London. Anyone want to hazard a guess for what the curve looks like for an Australian city like Brisbane or Sydney or Melbourne? Yeah, let's have a look.
4 degrees, 5 degrees.
So those are the relationships in 3 Australian cities, done by the same technique. And so you're right, it is shifted to the right. That optimum temperature is more like 27 degrees. But you know, there's some cold-related mortality in Australia. Every time I say that, people laugh at me because it's not recognised. And so you can see that there is some days that are of much lower temperatures than you would normally be doing heat-related alerts, but that there is a degree of mortality. And I'm not actually showing you the graph that has been published in this report from Gasparini, but it actually shows that moderate cold-related deaths are far greater in Australia than heat-related deaths, either moderate or high. Okay. So they've now taken that further and looked at what will happen under various different representative concentration pathways of the IPCC. And this is for 9 regions in the world. You can see along the real bottom, I think you can see it quite reasonably clearly, the different RCP scenarios and the different decades. And what the blue is showing is that under most scenarios, there will be a reduction in cold-related mortality because of the increase in temperatures, and there will be an increase in heat-related mortality. And in some parts of the world, the net risk or the net cost of climate change will be really significant. So you could look at Southeast Asia, Southern Europe, South America, Central America, where it's clear, certainly at the right-hand side of those graphs, that the increase in heat-related deaths is going to far outweigh the decrease in cold-related deaths. But Australia is quite interesting, isn't it? That's Australia right at the bottom right-hand corner. That is almost suggesting that actually in terms of temperature-related mortality, climate change will reduce mortality, not increase mortality, temperature-related mortality. So that's quite challenging, and that's particularly challenging if you're wanting to communicate about the risks of climate change. And this can be used by people who are climate change deniers. And we've certainly been through that loop in England, where we did some of these analyses and showed that actually climate change would reduce our cold-related deaths significantly, and the increase in heat-related deaths wouldn't outweigh it. But then we realised that actually we weren't making any adjustments for what was going to happen to the change in population over time. We know that the population is ageing. We know that the level of vulnerability in terms of multimorbidity is increasing. And we know that a large number of different resources that we rely on are going to become more and more constrained. And it's absolutely true that in this analysis, they haven't taken into account ageing or any of those other changes too. When we did that in the UK on one specific study, we were able to show that actually the reduction in cold-related mortality wasn't really going to happen because of the increased pressure of our ageing, unwell population. So beware of that. If somebody looks at this and says to you, well, look, actually climate change is good for health, it's going to reduce your temperature related. Yeah, please.
Angie, sorry to interrupt, but just on these kinds of modelling scenarios, I'm just wondering, is it helpful or harmful to model things that we don't fully understand the complexity of? Because these systems change all the time and we don't know what we don't know. And putting things into a model, you can spit out any number of different kinds of pictures. So just curious your thoughts.
Yeah, no, I agree that, yeah, you're absolutely right. What you put in manifestly changes what you put out. I think it is helpful as long as it's not taken as gospel. I think we are constantly having to try to make the case for investment, and we are constantly being asked about numbers. And certainly from a politician's and from a treasury perspective, if you don't have numbers, it's very, very difficult to get any resourcing. So I think, however much we'd like to say, perhaps, oh, well, there's so much uncertainty, we can't do anything, I'm not sure that that is going to actually help us drive things forward. But I think we do need to, if we're doing modelling, spend the time to explain what that means, what has gone in, what is coming out, and how to interpret that. But it's a point very well made that it's difficult. But if we don't at least try to quantify what might be happening, then I think we will just be not taken seriously. Yeah.
I just go back to one of the things you were talking about in terms of elderly, so an increasing multimorbidity aged population. Doesn't that still affect both extremes of temperature? So when you said you put that into the model, wouldn't that still have meant that in the colder temperatures you were still getting a bigger increase there, but a bigger increase in the hotter temperatures too, that doesn't disproportionately affect the hotter temperatures, the older population? Is that right?
Yeah, it's the same for cold and heat. You're absolutely right. Maybe I wasn't clear enough in my explanation that the big in the UK. So each year at the moment we have around 40,000 cold-related deaths, and we have around 2,000 heat-related deaths. They're not recognised often because, as I say, they're not labelled. They're not hypothermia and heat stroke. They are cardiovascular and respiratory disease deaths that are related to temperature. So as the temperatures get warmer, we will have a little bit of a drop in the cold-related deaths, but because of the ageing, that's not going to make that much difference. In terms of the heat-related deaths, we will have a little bit more heat-related deaths because of ageing and all of those things, but the 2,000 versus 40,000 means that that relative increase doesn't really make a significant difference. Am I making some kind of sense there? Yeah. Okay, right, I'm going to carry on then to the next bit, which is this. This is, I just wanted to let you know a little bit about our experience about how we use these curves actually in public health practice now. So as I say, I was running the cold weather plan for England, and the cold weather plan started off life as being an emergency plan essentially. So once temperatures got below a mean daily temperature of 2 degrees, cold weather alerts would go out. But working with the London School of Hygiene and Tropical Medicine, they were doing an evaluation of the plan. And they started doing some of this EPI stuff, this very clever regression modelling. And so this is just one of the data outputs. And this is for the northeast of England. And it's looking only at deaths happening between October and March, and looking at the attributable fraction of various different temperature thresholds. So again, you have the line graph, which is not unexpected, which is showing you that we have an increase in mortality from around a mean temperature of 6 degrees. And you have the histogram behind it, which is showing the number of days at these various temperatures. And in general, you know, the kind of median temperature is around 5 degrees in the northeast in winter. So taking all of that information and turning it into the graph underneath. Oh yes, the other thing I was just going to say is, of course, and most winters we don't have very few days at below 2 degrees. So we have about 30 cold weather alerts over the whole of England in a winter because of a mean temperature of less than 2 degrees. But looking at the graph underneath now and looking at the attributable fraction, this is essentially saying that top point there, I don't know if I can show you, here, this point here. If you say, okay, well 100% of cold related deaths happen below 6 degrees, that's what that top graph is saying. And then you look at the proportion of cold related deaths that occur at all of those other temperatures. So at 5 degrees, about 50% of your cold related deaths occur. And then you get to your 2 degree mark where all your action is, and actually 97% of your cold related deaths have happened already. So that then says that assuming that all of your actions that you do once you've got a cold weather alert out are 100% implemented and 100% effective, and do we know any public health intervention that is 100% implemented or effective? No. Then even then, you've only got the opportunity of preventing 3% of your cold-related deaths. So we saw that and thought, oh my God, we've got the threshold wrong. We must be, we must put it up. We must put it up to 5 degrees, then we can prevent 50% of those deaths. But if you put it up to 5 degrees, then you're having cold weather alerts out for 50% of your days in winter. And then what impact do they have? None. So we spent quite a lot of time going round and round in circles trying to work out, well, what do we do about this? And during that period, we were talking a lot with fuel poverty campaigners, people working around housing, who were saying, that even in these moderate temperatures, people are living in extremely cold, damp, unpleasant housing, and they can't afford to heat their homes. And I almost wonder, I haven't yet established it, whether there is a corollary in Australia around heat, that there is this perception that everybody has air conditioning and that actually there are big communities that don't have air conditioning who are overheating indoors, and whether there are heat impacts that are happening that are unrecognised, just as they were around cold homes in England. So what we did around the cold weather plan was maintain an emergency thing for emergency responses, and an acknowledgement that occasionally there will be a really tough winter where there is very, very cold temperatures for a long period of time. We need some sort of alerting thing. But we also transferred the bulk of our work into working around moderate temperatures, cold homes, poverty, etc. So that is where the cold weather plan got to. Yes?
Just going by what you said, like 50% of the days are under 5 or 6 degrees, and most of that mortality is within that range.
Yeah.
Does that mean it's just a bad metric? You should be measuring something else?
I'm not sure I understand what you mean about it being a bad metric.
So...
What would you measure?
Well, I'm not sure, but like you said, there were corollaries and other risk factors. But if that's the case, it doesn't sound like it's... Because there's like... the exposure is like 50% of the time. Yeah. Is there something else that was considered, or?
Yeah, I don't think it's about the metric. I think it's about the action. Is that the metric is measuring the impact. I think what we need is what is the action. So you could then say, well, okay, the action is around reducing fuel poverty. So let's start measuring the number of homes that are in fuel poverty, and that's what we were doing. So we know in most parts of the country, at least 10% of our homes don't have enough money to be able to heat their homes.
I wanted to ask with those models. We also know that flu and other infectious diseases cause a lot of excess mortality.
Yeah.
Do they account?
Yeah, that's a really smart question, and you're absolutely right. I should have said it. Yes, they do account for flu. They account for pollution as well, which is another one of the big confounders, particularly around respiratory deaths and cardiovascular deaths, in fact. Our pollution data isn't quite as good as our flu data. So there were some cities where it was possible to include pollution, like London. Other cities it wasn't because we didn't have the data, but where we did adjust for pollution, it didn't actually make that big a difference. Certainly around cold anyway.
You mean like particulates?
Yes.
Like air pollution? From stoves?
Yeah, absolutely. So cold weather plan now has a lot of emergency actions, but it also has a huge amount of actions working with local councils, working with allied health professionals, working with our Department of Energy and Climate Change, working with our gas suppliers to ensure that people are able to heat their homes. It's not perfect, and in austerity Britain, some of that has been difficult to keep going. But that has, I think, been very, very beneficial. And I guess I would ask you to maybe think about, is the corollary in Australia around heat? Should we be actually not just thinking about heat waves and alerts? Should we actually be thinking about people's home circumstances? Yeah.
Yeah, it's really interesting. And I'm just wondering whether there was any discussion about maybe government incentives for like insulation in homes and things like that, because I think New Zealand has been doing some initiatives in that space so that new homes have to have some insulation requirements, because obviously even having access to heating, you still have to be able to pay the bill that comes in winter, which I think a lot of people avoid using the heater to save costs as well.
Absolutely. There's been various different initiatives, either grants. There was something called Warm Homes, Healthy People. There was Warm Front, and yes, we worked a lot with New Zealand because they've been real trailblazers in some of the randomised controlled trials that they've been doing to actually show the impacts on health of improved energy efficiency and heating in the homes. So there's been a lot of work in that sphere. Okay, so that's the cold weather plan. What we've actually found through doing a lot of the insulation and energy efficiency is that we've been making our homes more and more airtight, but we haven't been doing anything about cooling, passive cooling, particularly. So we're now getting increasingly hot summers, particularly in towns like London, where we only have about 3% of the population have air conditioning in their homes. And by making our houses, particularly our social housing, which is blocks of flats that are often at the top of a building with no shading, often rather older people with no insulation, no shading, living on a busy road so they can't always open their windows, or there have been security things put in so they can't open their windows if they've got toddlers and stuff, that we're now quite surprisingly suffering with a lot of issues to do with overheating in homes. So indoor temperatures are now 38 degrees. I've been sent various different pictures of people's indoor temperatures, and we're having issues in our hospitals and in our care homes and in our prisons now that we have not adapted our housing sufficiently for the new climate. So alongside all of the work that we were doing around fuel poverty and insulation for cold, we've now started a whole stream of work around, well, if you're retrofitting to protect against cold, please think about how you're going to cool in summer. And so cool without air conditioning. So one projection is suggesting that by 2030, 70% of Londoners will have air conditioning in their homes. But that again is going to put a massive load on our fuel if we're using fossil fuels rather than renewables. So there's a big movement now to try to get to delay the time by which everybody starts needing to use air conditioning by looking at all sorts of different levels of passive cooling. So this is just some work that was done with Arup to try to characterise the risk profiles of different types of homes. And our Committee on Climate Change have just published a whole report on the importance of housing and health and climate change. So, and they're saying essentially that housing is producing a large amount of emissions in the UK, largely from heating rather than cooling, and that we are not going to meet our emissions reduction targets if we don't manage this better. So we improve energy efficiency, but we also adapt. And they are really very critical. I'll show you something later on about how we are lagging far behind what is needed in our domestic housing stock. So,
just had a quick question just to contextualise the social housing situation between the UK and Australia, particularly if you have to have quite a fair bit of retrofitting activities to encounter this. Can you just give us a bit more context about how social housing works in the UK?
Yes.
And how it's managed?
Okay. So housing is largely managed by housing associations who are commissioned by local government, so councils, to provide housing. So there are long queues to get onto social housing. There are various criteria for priority lists, but it's managed very locally by it's rare. It used to be that the councils themselves would provide the housing. Now it's pretty much commissioned out to housing associations who run that.
If I could just follow up, just with this move to sort of do a lot of retrofitting, but is there alignment currently after the Grenfell Tower reviews, for example, to sort of see where an opportunity might lie towards to sort of build this sort of this like climate action and efficiency into
Yes.
the inevitable changes that will come from
Yeah,
connection?
absolutely. And you'll be aware that the Grenfell Tower issue was in relation to cladding. That was partly done from an energy efficiency perspective, so that was very challenging as well for people who didn't feel that we should be investing in energy efficiency to say, look at that fire, look what happened when you did that. Yes, it is very clear in the housing world that we have to be thinking about safety and energy efficiency and adaptation at the same time. Our building regulations are managed by I think they're called communities and local government, the Department for Housing, Communities and Local Government now. It used to just be communities and local government. They've put housing in there because it's understood. And various different bits of regulation are now sort of being re-looked at. We have gone through a period in the UK where regulation was, there was a big move to deregulate. I think the Grenfell episode is now making people start realising that actually we do need to regulate. So as I was leaving the UK, most of the regulations were around energy efficiency and cold temperatures, and there was no real regulation around hot temperatures. So I was working on a research group with the Department of Housing, Community and Local Government to look at what the evidence was to support regulating for heat, to prevent overheating as I was leaving. Okay, there was another question? No? Okay, I'll carry on. Okay. So yes, I've been talking about that whole interaction between energy efficiency, climate change mitigation, poverty and health, but also the trade-offs that you sometimes have to make, that you can't always just think about these things in little boxes, that if we had thought about overheating whilst we were doing the energy efficiency thing, then we would have perhaps avoided some of the mortality and morbidity that we're seeing around heat. And this is, I think, the point that the IPCC was trying to make in their report last year, of the fact that actually mitigation in general is pretty good for meeting the Sustainable Development Goals. So you have the Sustainable Development Goals down the left-hand side, and then you have these three columns for energy supply, energy demand, and land use. And it's essentially trying to say that, that there are synergies, the blue, between climate change mitigation policies and meeting the Sustainable Development Goals. There are a few trade-offs that you have to be aware of. So in terms of energy supply, they're picking out in terms of trade-offs, water and land, because getting good water quality is actually pretty carbon intensive. So if we're going to put a big price on carbon, for example, because we want to reduce climate change, then there will be implications in our ability to get safe water or safe food. And so I guess the obvious conclusion then is that we need to save our carbon use for the things that we absolutely value, like safe water and safe food. But the space around health, so the SDG 3, which is the green one, the third one down, is in general, what it's telling us is that carbon mitigation policies are good for health. So if we care about health, we should be caring about carbon mitigation policies. And that's, of course, this side, the health and climate co-benefits. And I imagine that you're all pretty well versed in this, so I won't spend a lot of time looking at the time here. But essentially, as I was saying, active transport, energy efficient housing, a healthy diet, green spaces are all good for both climate, are good for health, and they are good for mitigating climate. Renewable energy is another one there. So now I'm going to just move over to the impacts of health services on climate change, because as I say, we often characterise the health services as the people who are going to suffer from climate change because of the increased demand. But actually we produce a hell of a lot of carbon ourselves. And you can see here that this is some work done on the Australian healthcare carbon footprint, indicating that hospitals are the biggest expenditure of carbon. You won't be surprised by that at all, I'm sure. This is some work done in England in 2010, actually looking at, well, where are the carbon emissions coming from? And I think everyone was pretty surprised to see that procurement not buildings, is actually the biggest element, and that's because of all of the carbon built into the supply, maintenance and use, and medicines particularly. So there's been a lot of work, for example, in trying to move to lower carbon anaesthetic gases, lower carbon dental practices, lower carbon procurement of inhalers. Inhalers, for example, are, the old-fashioned ones which you press, are very, very carbon intense apparently. So kind of moving on to more around the frameworks just for the last 10 minutes or so. We were trailblazers, I think, in England, in the UK, in terms of having the Climate Change Act of 2008. It was the world's first long-term legally binding framework. And the really good thing about it was that it was totally bipartisan. And that meant that it didn't become a political football between different groups. All of the people working on this were coming at it from all of the different political agendas. And I think, they're relevant from whatever political agenda you're coming from. It put in a legally binding target to reduce carbon dioxide emissions by at least 80% by 2050. The government, Theresa May, in one of her last things that she has done, has said that the government is proposing to legislate for net zero for all greenhouse gases by 2050. That just happened last week. I hope that follows through with whatever our new Prime Minister is, whoever our new Prime Minister is. It includes requirements for an assessment of the risks of climate change. So we have a 5-yearly climate change risk assessment, which is evidence-based. So it's based on an enormous amount of scientists coming together to produce an evidence report for the climate change risks and some recommendations. And then those recommendations are used to produce a 5-yearly national adaptation programme. And what I think has also been incredibly valuable by this is that it established an independent climate change committee who are scrutinising everything that government does, and they are vociferous in their criticism, which is very helpful if you're trying to move an agenda forward to improve things. So I work mostly on the adaptation side rather than the mitigation side. That is just a diagram essentially showing the process. So there's risk assessments, there's a policy response, and then there's reporting on progress. And there's a constant monitoring of trends of vulnerability. So our latest climate change risk assessment produced 6 priority areas for government. So flooding is the highest priority. Risks to health and productivity from high temperatures was another one. Water supply for agriculture, energy generation and industry. Risks to natural capital, particularly our soil, in its ability to be able to produce food. Risks to domestic and international food production and trade, and new and emerging diseases, so the infectious diseases. So what they did was they identified maybe 100 risks, and they identified which ones were where more action was needed, which ones were where there was a research priority, which ones were where a watching brief was just needed. Health features particularly in Chapter 5, which is called People in the Built Environment. Health doesn't appear in all of those priority areas explicitly, although I would argue that health is relevant to all, probably more relevant to others, to some than others though. And this is just a report from the climate change risk assessment around housing, just to kind of give you an idea of how tough they are. So at present, there are no comprehensive policies in place to adapt existing homes and other buildings to high temperatures. The level of risk from overheating across the UK is unknown for hospitals, care homes, schools, prisons and places of work. There is evidence that people lack a basic understanding of the risks and are therefore unlikely to take measures to safeguard their and their dependents' well-being. So that whole report is like that about every aspect. And that is pretty tough to read, but it's also quite useful if you are working at a government level to say this is action that needs to be taken. So one of the things that we've been really fortunate about is having a sustainable development unit in the health setting, in the healthcare setting. So this is a really small group of people. I think it's 5 FTE in total, used to be led by David Pension, who some of you may have heard talk when he came to the RCAP conference RACP, that's it, conference last May. So they have developed a strategy working across Public Health England, NHS England and local governments to produce a thorough strategy, and this was a real kind of co-production of getting people through a series of workshops to look at what they could do. The strategy essentially has a vision that a sustainable health and care system works within available environmental and social resources, protecting and improving health now and for future generations. There are 3 goals, so goals around a healthier environment, goals around the fact that communities and services are ready and resilient, and that goal 3, every opportunity contributes to healthy lives. And then there's a series of modules for specific things about how to deal with all of those little areas that I'm not going to read out there, but documents on plans for dealing with all of those areas, including one on commissioning and procurement. They've mapped the carbon footprint across the NHS, public health and social care in England. You can see the blue is where we've kind of been up to 2015, which is when it was measured last. And you can see where we are supposed to go to meet that original 2050 target, which is the orange, and the trajectory we're on. So this is kind of an industry in the UK which is working incredibly hard to save carbon and save money, and yet still is failing dramatically to meet the commitments. And so that is replicated across all sectors. So what is Victoria doing? Victoria has a Climate Change Act, that was in 2017. That started off with a meeting net zero emissions by 2050. It states very clearly that all decisions made by the Victorian government should take account of climate change, and that adaptation plans need to be developed every 5 years from 2021. Department of Health and Human Services is one of 3 departments that's doing a pilot climate change adaptation action plan at the moment, and also an emissions reduction plan. Our Victorian Health and Human Services Building Authority is doing a lot of work around the Greening Government Buildings Programme, large investments in making hospitals more energy efficient and saving carbon, and a big regional solar health programme. I gather that we have a hospital that has the largest solar array across Australia. That said, despite all of that investment, it's only reducing our carbon footprint by about 1%, when we know that we've got interim targets of around 38 to 45%. So we're still a long way from where we need to be. Our public housing colleagues are they're requesting that design of all new housing is 7-star. They're doing some really interesting energy retrofit stuff in 1,500 of their existing dwellings, trying to look at what are going to be the most appropriate combination of features. And we have the Victorian Healthy Homes programme now, run by Sustainability Victoria. They're repeating the randomised control trial that was done by Otago in New Zealand to look at what the impacts on self-reported health, and possibly also actually verifying data of interventions to improve heating and energy efficiency in Victorian homes. I don't know if you're aware of the Centre for Disease Control in the US's BRACE programme, so Building Resilience Against Climate Effects. This is their major way of providing a framework for all of the different states to be able to assess their vulnerabilities and project what the likely disease burden is going to be, looking at all of the different public health interventions that could be put in, developing their own climate and change health and adaptation plan, and evaluating impact. So it's a classic risk management type approach. because it's come out of the very kind of epidemiological focused bit of CDC, there's a lot of focus on how you actually assess vulnerabilities. So there is some very nice maps of, I don't even know which part of the US this is, but mapping all of the different vulnerabilities and risks together to find out where in each state, where the areas of most risk and vulnerability are, so that's where actions can be targeted. And lastly, I just mentioned the CAHA framework for a national strategy on climate, health and wellbeing for Australia. This is still not formal policy, but I do think that it is a really, really good, sensible and very comprehensive approach to pulling together all of the different elements that you need to be able to respond appropriately to climate change, but also to have awareness of all of the principles, that wider circle around the outside that is very much around that rights-based, community-based approaches, and things like intergenerational equity. So with that, and where I'm probably gone on for a little bit too long, I'm going to stop. Thank you very much.